Hello, welcome to the Geri Academy podcast with your host, geriatrician Dr. Golnur Sharif Saleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media. Hello, welcome to episode number 12. And today I wanted to talk about really defining dementia and some of the more common types of dementia. In episode 11, I discussed warning signs, maybe abnormal signs that warrant attention and evaluation. So if you haven't listened to that one, it's quick, it's brief, it's 13 minutes. Check it out. And before I start, I just wanted to thank everyone for listening in. I was looking at the analytics, and most of the listeners are from the US, but I'm also finding people from Canada, United Kingdom, Malaysia, Mexico, Australia, Finland, Indonesia, Spain, Ecuador, Slovenia, Singapore, Israel, Netherlands, Ireland, India, Germany. So thank you so much for listening, and I hope these podcasts are helpful. All right, so let's get started and to the point. So first, let me just talk about dementia like an umbrella term. The Alzheimer's Association does this beautifully as well. But, when we think about dementia, it basically means loss of cognitive function. And so what's cognitive function, right? That's impaired ability to remember, to think, to reason, solve problems, recognize the date or time, having difficulty with speech, carrying out day-to-day tasks, planning out events, right? We refer to sort of this day-to-day task, planning out events, executive function. So you might hear that term thrown around by your dementia specialist. And so now that we know what cognitive loss is, and dementia basically is loss of cognitive function in two or more of those cognitive domains. And there are different types of dementia. So think about dementia like an umbrella term, and then you've got different types inside of that umbrella. The most common type is Alzheimer's dementia. It's impacting about or more than 5 million people over the age of 65. The onset of this disease is usually gradual, over 8 to 10 years on average. And the symptoms include primarily memory loss, difficulty learning new information, language and visual-spatial problems. So having difficulty seeing objects in 3 dimensions, people really start having trouble driving, sometimes unable to distinguish between steps and falling. So the disease progresses until there is no function to preserve. And that basically means people will not have the ability to feed themselves, dress themselves, use the bathroom by themselves. And unfortunately, just keep in mind that dementia is progressive and it's terminal. We do not have a cure yet, but we have support, help, and some treatments that can delay progression. So stay tuned for those podcasts. Anyway, so the next type of dementia that's pretty common is vascular dementia. And this type of dementia causes memory loss and cognitive function due to vascular injury to the brain. The severity of the disease depends on the size and location of brain injury, right? So sometimes it's hard to distinguish the type of dementia from Alzheimer's type. It's actually really difficult to distinguish different types of dementias from each other unless you are seeing a dementia expert, because they have had so much training in seeing so many different types of dementias, because it's what they do most of the day, that they may be able to narrow it down better. And narrowing down the type of dementia may actually help loved ones and caregivers and the patient in managing the dementia symptoms better. So sometimes, this type of dementia, vascular dementia, can be caused because of strokes, uncontrolled blood pressure, diabetes for decades, or uncontrolled blood sugars, high cholesterol, and other risk factors include smoking, unhealthy diet, obesity, and little to no exercise. So it usually takes like a stepwise approach. The other day, I had a patient in the office whose family member said, well, mom was good for a while, and then she had her stroke, and then she lost some function, and then she was good for a while, and then it seemed like she went downhill again, and then she was stable for a while. So do you see that? Picture that, a stepwise decline. And sometimes the way I describe vascular dementia to people is imagine your brain is like a Christmas tree and all the lights it's like the brain activity that's going on everywhere. And as little lights go out here and there, and you step back and look at the tree, you don't really see the difference. But once you have a patch of lights out, right, and you step back, you see that. And that's kind of what vascular dementia is. Over time, you have these tiny little insults to the brain. And because of sort of this clustering effect, the effect can be additive and you can start to see memory problems, behavioral problems. It just depends on where the damage is. So another very common type of dementia, and I would expect more people to know about this type of dementia, but they don't. And I think it often gets underdiagnosed. I've had patients who come into the memory clinic to see me and they're like, oh, I was given the diagnosis of Alzheimer's. And then they have like classic Lewy body dementia symptoms. I'm like, nah, I don't think it's Alzheimer's disease. And sometimes they have a brain MRI. We can look at the images, and I usually will confirm with my neurologist, and then we give them the diagnosis of Lewy body dementia. So it's pretty common. It starts a little bit earlier, right? So Alzheimer's dementia, generally patients start to experience symptoms after the age of 65, unless they have genetic variants and they have early onset Alzheimer's dementia. But with Lewy body dementia, usually begins after the age of 50. It's in rare instances, it can actually even be earlier than that, but it's caused by an abnormal protein in the brain, and this protein is called Lewy bodies. So symptoms vary, but generally include memory loss, other cognitive losses like we discussed above, behavioral issues like agitation, hyperactivity, depressed mood, sleep issues, and more commonly, patients with Lewy body dementia experience hallucinations, and sometimes they experience tremors, like Parkinson's-like tremors. So they may have a shuffling gait, where walking and shuffling. And, patients with later stages of Alzheimer's dementia can also have this shuffling gait. But, classically with Lewy body dementia, you start to see some of the gait stuff, the tremor stuff a little bit earlier on. And you can really distinguish it, or I can anyways, and a neurologist can anyways, really distinguish Lewy body dementia from Parkinson's, because usually with Parkinson's, patients have tremors first, and then later on, like up to decades later, sometimes 10, 20 years later, sometimes people with Parkinson's can live that long, patients will start to develop the memory loss and the confusion. Well, with Lewy body dementia, the memory issues can manifest earlier on, right, alongside those Parkinsonian symptoms. And these patients generally experience hallucinations. And, with vascular dementia or Alzheimer's dementia, you can also experience hallucinations. But usually with Alzheimer's dementia, only about 10% of patients experience hallucinations. But with Lewy body dementia, more people experience hallucinations. Another telltale sign of Lewy body dementia includes something we call REM sleep disorder, where people act out their dreams. They get up and they're screaming and having these very vivid dreams. And, it's really important for us in a memory clinic to get this very comprehensive history. And the imaging, again, is very different, right? So an MRI picture of Lewy body dementia is going to look different than an MRI picture of someone who has Alzheimer's disease. And just saying that doesn't mean that an MRI is going to diagnose a dementia. It helps us kind of understand the disease a little bit better. So the next kind of dementia that is, again, not as common, so less common than the first three, is called frontotemporal dementia. I'm not sure if any of you have heard of that, but it is usually seen in people that are younger, generally 60 years and younger, and patients develop cognitive loss such as planning tasks, memory issues. Usually patients with frontotemporal dementia behave differently than they used to. They start to have emotional instability, they become impulsive, and it really is because of the areas of the brain that are affected. The course of frontotemporal dementia is about 2 to 10 years, so a little faster than the others. And again, an MRI is really helpful to understand, or just any brain imaging, right, is really helpful. So when you go to a memory clinic, usually geriatricians are in memory clinics or neurologists, and we see that a person is presenting at a younger age, we go ahead and order imaging and also other lab work, right? And stay tuned because there are now possible medications coming out, and we haven't really had anything for the last 20 to 30 years. It's different in terms of treatment, but we may have new treatments that could possibly slow down the progression, and it may mean that we really need more testing, specialized testing like lumbar punctures, imaging, PET scan, which is something I'll talk a little bit more about when it comes to the memory evaluation podcast that's going to come next. So then we have the neurodegenerative dementia. So other dementias have been identified that cause cognitive decline, and they're not related to those more common types, right? And one of those is Creutzfeldt-Jakob disease. This is called CJD. This type of dementia is related to usually infection, we think, something called a prion, which is not virus, which is not bacteria. It's like its own thing, right? Patients usually rapidly decline and usually live about 1 to 2 years after the diagnosis. It's so devastating. I have to tell you that since I started my fellowship and graduated and have now been working as a geriatrician for like 10 years, I've seen one case of this, and most people do not encounter this type of dementia in their career. So very, very rare. And I really had to work closely with our neurologist so that we could define this and identify this and provide support for the family, because this patient was rapidly changing and declining so quickly. So another one of these that it kind of came about in the media is chronic traumatic encephalopathy, so CTE. And this is where we talk about traumatic brain injury, right? The football players that develop CTE, it generally occurs in individuals who've experienced multiple concussions, like, horseback riders who fall off a horse multiple times, football players. That was the classic. It was on the news for a while, had a lot of attention. And symptoms include memory loss, mood and behavioral changes, balance issues, tremors similar to Parkinson's disease. And generally those with CTE start to present with symptoms like at least about 20 years or more after that repeat injury. And so this is why you see football players who begin to have these cognitive disorders present with symptoms, in their 50s and 60s, and then they were playing football in their early 20s and sometimes into their 30s and maybe some into the 40s. Anyhow, and then other diseases, right, like Huntington's disease, HIV can have some dementia types of symptoms, Wilson's disease, multiple sclerosis, meningitis, encephalitis, and others. And then we also have these like non-dementias, right? So when you come to a memory clinic, not only are we evaluating you for dementia, but we're also looking at these reversible causes, like vitamin disorders that can look like dementias, or, tertiary syphilis, depending on what the person's history was that never got detected. And, geriatricians, I'll be honest, we're really good at distinguishing different types of dementias and really evaluating people for dementia. It's because it's a big part of our training when we're in fellowship. And, fellowship is additional training after we have completed an internal medicine or a family medicine residency. For me, it was family medicine, and it was awesome. And then I went into a geriatric fellowship. So I hope that this podcast episode was helpful. Like I said in episode 11, I am now trying to keep these like short and to the point, just like the blog posts, because I really want patients, loved ones, and the general public to have the meat of the information. And I'll still continue to do some of the other podcasts with guests because I love having experts in the area talk to me about the information that they can provide you. But these episodes will be to the point and you'll get the valuable information that you need. Anyhow, tune in next time to our next episode, and please email me at jerryacademy@gmail.com with any questions. And if you need a geriatrician, it's a super exciting. I have opened a brand new practice in Asheville, North Carolina with my partner, Dr. Kate Marshall, and she's just beautiful and lovely. Our practice is called Golden Oak Medicine. All right, well, have a great day. Thank you. Bye. Thank you for listening to this episode of the Geri Academy podcast. Learn more at geriacademy.com or follow me on social media for information on future episodes.